Hi, good evening, and welcome to the Together Facing Pancreatic Cancer event. I'd like to thank our patients, our caregivers, our survivors, our advocates, and our guests for joining us this evening on World Pancreatic Cancer Day. I'm Crystal Denlinger, medical oncologist and chief of the Division of Gastrointestinal Medical Oncology. I also direct the survivorship program here, and I'm very excited tonight to be joined by some amazing colleagues at Fox Chase to talk about pancreas cancer. Tonight, my colleagues and I will share the latest research and treatment developments for pancreatic cancer. We typically gather in person for these events, and we have in previous years, and we wish that we could all be together again today for this. But we hope that what we have planned for you this evening will be both inspiring and informative despite the virtual format. Throughout the program, please feel free to leave questions in the chat feature on Facebook, and then at the end of, towards the end of the program tonight, we're going to have an interactive chat with our faculty members. So as we get started tonight at our Together Facing events, we traditionally begin by honoring those who we've lost to cancer. We recently lost Alex Trebek to cancer, and I know that there are many of you who are dealing with loss as well. And so please join me for a moment of silence, remembering those we've lost to cancer. Thank you. I'd also like to take a moment to thank our exhibitors for this evening. It's because of their generous support that we can offer this free program to you tonight. We'd like to especially thank our gold exhibitors, Bristol Myers Squibb, Caris, Foundation Medicine, Genentech, Guardant, Natera, Oncosec, Tempus, and Neurogen, as well as our silver exhibitors, AbbVie and Ipsen Biopharmaceuticals. And I'd also really like to thank both of our patient advocacy groups who are joining us this evening, PanCan and the Lustgarten Foundation. I'd like to thank them for their ongoing partnership and support, both of our own research programs and then within the larger pancreatic cancer community. So at this time, I'd really like to introduce the panel for the evening. What I would like to do is have each of our panelists introduce themselves, basically your name and your work at the Cancer Center. And then what we're going to do is have each panelist take about 5 minutes to talk about something specific to what they're doing in pancreatic cancer research. And each one of the panelists will have a chance to sort of tell you a little bit about the latest in their particular field of pancreatic cancer research. And then after that, we'll go on to the interactive questions. So I'd like to first introduce Dr. Igor Asadarov. If you could just tell us a little bit about yourself and your research in pancreas cancer.
Hello, everybody. My name is Igor Asadarov. I serve as a attending physician, and I also run a research laboratory at Fox Chase, which is entirely focused on pancreatic cancer. This is something that is very personal to me. My wife died of pancreatic cancer 7 years ago. Elena. She was a faculty at Jefferson, and this horrible cancer took her life within almost less than a year, and there was nothing that we could do for her. But our commitment to the cause is driven by the need to acquire better knowledge of what drives this tumor and how we can find vulnerabilities. Because many failed clinical trials and a very limited number of options that primarily as a result of just basic lack of knowledge, like what drives this tumor, what is the interaction between cancer cells and microenvironment, what is the metabolic change in cancer that produces such an incredible propensity to weight loss and exhaustion, cachexia. What are the chemo-resistant cancer cells that drive poor outcomes? So these are the kind of questions that we are asking ourselves. I'm very not only optimistic, but I think the way we set it up at our institution, based on really true friendship and collaboration and shared enthusiasm for the cause. This is what drives our group in general, and I think this is what is the foundational principle, how we can make a difference in this cancer and really not only take good care of our patients, but also offer them better opportunities to be cured or to live longer and better quality of life. So this is our mission, and through a very generous donation of Conchetta Greenberg, in the memory of her late husband, Marvin Greenberg, who was a physician practicing at Einstein, who passed away from pancreatic cancer. She donated a significant amount of money to really reinvigorate the effort at Fox Chase and other places to really drive, give the instruments and the opportunities for people to develop better treatments for pancreatic cancer. So we've been working with her support in various directions. Our goal and ultimate aspiration is to bring new drugs to clinical trials. Besides learning the biology of this disease in animal models, we really are driven to understand better what's wrong with this cancer in actual human patients. So we are launching this coming year 2 additional clinical trials, and on top of the one that is already has already started by led by Dr. Meyer and my colleague Dr. Edna Kuckerman, to understand how radiation and stroma in pancreatic cancer interact. And on the same theme, we are actually trying to bring new medications and new modalities to understand what makes cancer resistant. Can we bring any medicines that would suppress the cancer stem cells? So these are the fundamental questions that we're trying to address, not only in mice, but also in humans. So I'm looking into the future with great degree of enthusiasm, not only because we put a lot of effort and financial investments, but also we got grants. We published well this terrible 2020, despite all the difficulties. Without any further ado, I really would like to listen to my colleagues who are behind all these news and all these great developments that we're really enthusiastic about.
So Dr. Kuckerman, you are the PhD on the panel today. So tell us a little bit about yourself and what you see moving forward from the basic science side of pancreatic cancer research.
Hi, yes, this is a great opportunity for me to be able to talk and meet all of you, because really, as you mentioned, I'm the only PhD in the panel, and being in a center like Fox Chase Cancer Center has allowed me to be able to talk with clinicians one-on-one and bring to the clinic the basic science aspects of the disease. And so what we've been seeing lately coming up as basic scientists for the clinic is in several ways. One is there is a lot more effort in trying to come up with early detection ways to recognize pancreatic cancer. It's really behind the scenes. There is nothing yet that I can speak of that we will have immediately, but there is a great effort and a lot of multidisciplinary aspects put into that type of research, because it is one of the things that is the most needed. Other things that are coming up that there is also a lot of effort behind the scenes is trying to figure out how the natural organ gets recruited to assist pancreatic cancer, and how it tricks the cancer or tricks the body into not killing the cancer. We need to figure out a way to regain the ability of the immune system to be able to attack the cancer. And the neighborhood of pancreatic cancer is very avid in tricking the system and turning it off. And so a lot of research behind the scenes is being done to try and figure this out. And there's a couple of papers that many investigators helped us publish. Together with Igor, we have had 2 main papers coming out lately that speak about how the neighborhood of the organ literally feeds the cancer cells, and we're trying to starve them. And the other way is to turn how this environment turns the immune system off, and we're trying to turn it back on. So I think those are the main things.
So even as a basic scientist working in the Cancer Center, you're able to help drive some of those future clinical research questions that then the rest of us on this panel as physicians are able to bring into the clinic.
Right. It's really exciting for us because, it's not just that we see some cells in a plate or we get some mice sick and try to make them better. Is that what we see in the laboratory, we can then hypothesize that we'll be able to follow in patients and then design and help you guys design the clinical trials so we can obtain some samples from the patients and test the hypothesis that we propose based on the medicine that you give the patients and see whether they really truly are efficacious in targeting the type of cells and the type of signaling that we think that these drugs are doing inside the body. So we have the opportunity to be able to come up with ideas, to have you guys listen to us, and to collaborate when we are trying to ascertain our thoughts in real experiments, first in the lab and then with patients. And I think that Dr. Meyer will speak a little more about that, with a great opportunity that we had in collaboration with him to actually be able to participate in clinical trials as basic scientists, which is, a comprehensive cancer center like Fox Chase allows us to do.
Yeah. So that's terrific. So Dr. Dotan, if you can now talk on the clinical side of things, you not only are a clinical trialist in pancreas cancer, but you take care of some very special patients and very vulnerable patient populations. So tell us a little bit about who you are, and tell us actually a little bit about how we have to think about our older adult patient population with pancreas cancer, as well as those who might be at familial risk.
Thank you, Crystal, and hi, everyone. Good evening. My name is Efrat Dotan. I am a medical oncologist from the GI oncology department at Fox Chase, and I treat primarily pancreatic cancer patients. I also am the principal investigator for all the pancreatic cancer studies that are going on at Fox Chase, and work very closely with everyone here on this panel to try and develop studies that are across all these disciplines: radiation, surgery, basic science, and really try and bring everybody together. The other hat that I wear is I'm also interested in geriatric oncology, and that's really trying to think about how do you treat and care for patients who are older and maybe more vulnerable and still want to treat their cancer, and we can help them prolong their life and feel better with this disease. So really the challenge with taking care of patients in this category is that we don't really have a lot of data on how to use the treatments that we have in this patient population. All the studies that have been conducted in young, healthy patients. And when someone doesn't fit that bill, it's very hard to know what treatment we can give them and how they will tolerate this. So a big step forward is through studies that are specific for older patients and trying to really refine the therapy. And I always think about tailoring the treatment not just to the cancer itself, but also to the patient in front of you, their challenges, their issues, with whether it's with other medical issues, other medications they're taking, any functional issues, any support issues. So really looking at the patient as a whole and understanding everything that they need aside from just getting the chemotherapy. And I think that's a big part of treating patients that are more vulnerable. Pancreatic cancer is a disease of older patients. Most patients with this disease are in their 70s, and we really need to think carefully when we treat patients who are not absolutely fit. And that's where my research comes into play. As Dr. Denlinger asked me, I'm also thinking a lot about other factors that influence the patient's care related to any hereditary factors that could influence their cancer. And we know now that pancreatic cancer is not one disease. Different patients have different diseases, and they're influenced by the genetic profile of the patient. And definitely the there are familial disorders that, or hereditary conditions that predispose for pancreatic cancer. And when we can identify those, we can actually refine the treatment. I'm going to say that I signed the chat on Facebook. One of my long, survivor patient that we identified as a familial carrier of a certain gene that really transformed her therapy and her outcomes. And it is just so wonderful that today we're able to identify these patients and give them the right treatment. So genetic testing has really become a significant part of how we treat patients with pancreas cancer and how we evaluate them and how we tailor their therapy. I think if one thing you can take out of this panel and this meeting today is the fact that we're all thinking about personalizing the treatment for pancreatic cancer, whether it's to the biology of the tumor or to the patient's clinical features or their fitness, whatever it is, it's a team approach, and every patient should have that kind of approach when they're facing pancreatic cancer.
So it sounds like pancreas cancer therapy is really now not just a one-size-fits-all thing, that there are very specific things that we have to think about in terms of the genetics of the tumor, the genetics of the patients, the individual characteristics of a patient. So how does that fit with lifestyle and how we approach things other than just the treatment and the other components of care that are really important? So Dr. Jane, why don't you introduce yourself and talk a little bit about how nutrition and management of some of these other factors that happen in pancreas cancer really play a role in moving therapy forward?
Yeah, great. Thanks, Crystal. So my name is Rishi Jain. I'm one of the GI medical oncologists here at Fox Chase. And I do treat patients with pancreas cancer. And it is a challenging disease, as you've been hearing from my colleagues here on today's call. So one other aspect that makes pancreas cancer challenging is that the tumor and the interactions between the tumor and the immune system lead to a lot of inflammation in the body. And that inflammation and the subsequent weight loss and muscle loss that occurs is called cancer cachexia. And you may have heard that term in other diseases as well, but it can occur in pancreas cancer, and it can be a very challenging situation for the patients and their family members, because it's not uncommon that patients with this disease present after losing 10, 20, even 50 pounds before they're ultimately diagnosed with this disease. And that's all because of that cancer cachexia, that occurs because of this inflammation from this cancer. So at Fox Chase, we are looking at ways to decrease that inflammation. We have a clinical trial open where we're looking at chemotherapy plus an agent that blocks this cytokine or inflammatory substance called GDF15. So we're looking at very interesting, strategies to overcome that process that complicates cancer cachexia. On the nutrition side, we do encourage patients to stay active and try and eat healthy during therapy. Crystal and others have done a walking study for patients who have pancreas cancer. And I'm doing studies as well, looking at ways to improve patients' diet, looking at computerized technologies to assess what people are eating and how that changes before and after people start chemotherapy. Because as many of you have probably, faced, that your taste changes both from the cancer and the chemotherapy. There's a lot of issues that can arise nutritionally over time. So make sure you talk to your team, meet with a dietitian, and I look forward to hearing more from our colleagues today.
It sounds like, too, that one of the issues that pancreas cancer patients have to deal with is pancreatic enzyme insufficiency, which is something that we don't necessarily deal with other GI cancers. So, Rishi, what is your sort of advice for people who might be worried about this, or what are the things that they should be talking to their doctors about with respect to pancreatic enzyme insufficiency?
Yeah, so one of the jobs of the pancreas is to produce these enzymes which are secreted into the digestive tract and help us digest the food we eat and ultimately absorb some of those nutrients, especially fat absorption is a result of this pancreas enzyme called lipase. So unfortunately, when patients have a tumor in the pancreas, the tumor can prevent the normal function of the pancreas, and the enzyme production can decrease, and therefore patients can not absorb their fat from their foods, and that can contribute to this malnutrition. And it can also just be very uncomfortable. Patients can have bloating, cramping, and then ultimately a lot of gas and fatty stools. So at some centers, they test stool for the enzymes. At Fox Chase, we generally just start all of our patients, or most of our patients, especially if they have symptoms of pancreatic insufficiency, on pancreatic enzymes, because we want to prevent some of that fat malabsorption that can occur.
Yeah. So, Dr. Meyer, we've done a lot of talking about some of the vulnerable populations, some of the things from a diet perspective or a lifestyle perspective and symptom burden that we can change. But there's a lot of new things that are happening for localized therapy with pancreas cancer. And certainly as a radiation oncologist, there's been some really new techniques that have developed over the time. So why don't you tell us a little bit about yourself and what new techniques and technologies we're seeing moving into the pancreatic cancer space?
Sure. So it's nice to be here. Thank you for the opportunity. And it's nice to envision all of you out there. I can't actually see you, but I know that you're there. And I've even had a couple of patients tell me that they're going to be there. So I think I want to pick up on a couple of themes that have already been talked about, but in a different way. So I'm a radiation oncologist, and I treat GI cancers and spend a lot of time treating pancreatic cancer. And there are lots of ways that radiation can be helpful for patients with pancreatic cancer. There are a few things that we've been doing recently that are actually somewhat new, and I want to touch on those a little bit. So, we were talking, Dr. Dotan was talking about how you really have to match the treatment to the patient. And we have to think about the whole patient when we give our treatments. And that's, I think, to me, one of the really exciting things about being a radiation oncologist now for pancreatic cancer is that we have a lot of options. One new option is a treatment where we give, instead of the classic 6 weeks of radiation, just 5 treatments of radiation. But they are more precise, they are higher dose per treatment. And in some situations, that is a great treatment for patients who need treatment quickly. It's also a great treatment for patients who are not really patients who will tolerate chemotherapy very well. And this is a radiation treatment that works without chemo, as opposed to most of them that require chemo along with the radiation. So that's one new treatment. It's called SBRT. And it's a treatment that we're excited about in the right context. Another treatment that is interesting is a sort of reversion back to the old-fashioned treatment of 5 weeks. But the difference is now we're able to deliver doses of radiation that are much higher than we used to be able to do, and do that safely through a number of technical tricks. The main one being we're able to treat patients while the patients hold their breaths. And that allows us to keep the tumor still and treat a much smaller area more precisely. And it makes a huge difference in terms of what we're able to do safely. And our control of these tumors is apparently significantly better than it used to be with our standard radiation. So again, in the right setting for the right patient, that is another new treatment. But the last one I want to focus on is actually the one that Dr. Astaturov and Dr. Cooperman were mentioning before, which is this clinical trial that we're running for pancreatic cancer. And it's really, if I can tell it briefly, a great Fox Chase story. I had a medical student who was working with me who was giving a short presentation about some work he had done with me to look back at a new technique of radiation that we were using. And there was probably 20 seconds of that was particularly interesting to Dr. Cooperman. And she came up to me after that little presentation that he gave, and she said, that thing that you were talking about and the scientific thing that she was particularly excited about was something called TGF-beta. I think that's really interesting because it's similar to something I've been seeing in my lab. And that opened up a whole line of investigation where we started testing this technique on the pancreatic cancer models that she looks at in her lab. Ultimately found out that this looked, I think, probably better than either one of us could expect in her lab, and was then enough of an impetus for us to start a clinical trial testing that in patients. So now we have this trial open, and we are treating patients with this special new radiation technique for pancreatic cancer that we are hoping will be more effective at treating the cancer. And we have good reason to think that it may be true. So I think, to me, it was an exciting story of two people who really had not worked together before, who didn't even really know what each other did, frankly, and were able to come together and produce something that we hope may be useful for patients in the future. So I think it's the kind of thing that we're all trying to do here.
This is exciting because we're really growing some of the research from bench to bedside and back again. And certainly that's true in the radiation field, but it's also true in the surgical field and in patients who might have localized disease. So Dr. Reddy, you're a surgeon that focuses on pancreas cancer. So, there's been a lot of thoughts about how to sequence our therapies and when to give which therapies. Typically, pancreas cancer therapy or pancreatic cancer therapy involves multiple modalities. So as the surgeon, why don't you tell us a little bit about yourself and how you see the surgical field moving forward, and maybe where there may be some windows of opportunity and uses of total neoadjuvant approaches.
Thank you, Crystal. So first of all, good evening, everybody, and thank you for participating and joining us. I'm an associate professor in the Division of Surgical Oncology at Fox Chase. I'm also the associate program director for the fellowship. And, the role of surgery really hasn't changed much over the years. And what has changed, though, is that we've made subtle improvements in the technique. So before I talk about some of the research stuff, I'm going to talk about some of the surgical stuff that we've done to really kind of enhance the results and recovery. So we are, a firm believer in the enhanced recovery protocol, where we utilize, minimizing narcotics, utilization of epidurals to really kind of help with postoperative pain control, taking out drains early, feeding early, to kind of maximize efficiency and get people out of the hospital, at a reasonable time frame so they can get back to their lives. The other thing that we've been doing more and more is utilizing the robotic platform for a lot of pancreatectomies. Now, again, it's very individualized, but it does offer to certain patients smaller incisions, quicker postoperative recovery, and again, a much quicker return to their normal, daily lives. Historically, here at the center, we've promoted this idea of what we call total neoadjuvant therapy. And this is kind of where my academic interests lie. And this is what's really special about the center here, is that we've learned that pancreatic cancer is not a disease where one specialty is going to, be the end all be all. It's a combination. It's the surgeon, it's the radiation oncologist, it's the medical oncologist, and it's the scientists. And using, this complete 360-degree approach to cancer treatment has really kind of changed the platform of how we're delivering therapy and ultimately the results. So, Dr. Meyer had touched on a couple of trials that, we've been working on. There's other things that, utilize, radiation sheets at the time of the surgery, where we can implant these sheets to direct therapy to specific areas or targets. I'm looking at a project now analyzing pancreatic duct fluid before diagnosis and after therapy, to see if there's any signatures that may change that may say this person does better than that person and why that's the case. I think that there's other trials that we have available, specifically this window of opportunity trial, where we're utilizing this window between chemotherapy and radiation and then ultimately surgery to implement specific treatments in that window that may alter the stroma of pancreatic tumors and ultimately survival. In our current healthcare climate right now, there's been a lot of high-profile cases out there. The passing of Alex Trebek, Ruth Bader Ginsburg, Congressman John Lewis. The list goes on. And what this really shows is that pancreatic cancer affects all walks of lives, and it's not just going to affect one certain individual. It's really a broad-based group of people. And I think what we need to really realize by the end of tonight's event is that there is hope for this disease. And even though we're moving this needle in very, very small increments, it's moving. And really through outreach, communication, research, and a team, we'll beat this. And the one thing you'll gather from tonight's event, again, is that it's really a team effort. And the patients are part of that team. And, surgery is a small part, chemo is a part, radiation is a part, and the science behind it is a part. But together as a group, we really kind of, can make a big dent and a big impact on this disease.
Thank you, Dr. Reddy. So that was a great way to end the sort of didactic portion of this event. And so we're now going to open it up to questions from the audience. I've already started to get a few questions, but please feel free to drop your question into the chat. And if we don't get to your question this evening, we've got about 20 minutes to really start talking about questions. But if we don't get to your question this evening, we will follow up with you after the event concludes by email, electronically. So our first question actually came from someone who submitted this question prior to the event tonight. And basically, there have been some talk about clinical trials based on immunotherapy, and there's been a lot of excitement in multiple diseases about immunotherapy and the use of various immunotherapy technologies in the fight against cancer. Do we think that this is something that could be effective in pancreas cancer? And if so, how does one become a candidate for a trial using an immunotherapy platform in pancreas cancer? I'm going to give that question to Dr. Jotan to start with, but I'm also going to then ask Dr. Meyer to speak a little bit about this.
So definitely immunotherapy has changed how we treat cancers, and the whole field is really excited about these opportunities. Unfortunately, in pancreatic cancer, we haven't yet figured out how to use immunotherapy, but I can tell you that there are many, many studies out there that are trying to combine new and novel immunotherapy techniques with older chemotherapy to try and improve the outcomes. We have one such study at Fox Chase that is really doing this and not using the typical immunotherapy treatments that you hear of on the commercials, but something more novel that would be able to penetrate this very aggressive cancer and open the door for our immune system to attack it. Some of the studies that we are doing at Fox Chase are thinking about that, thinking about breaking down this barrier that this cancer builds that doesn't allow the immune system to get in there and fight the cancer.
Dr. Meyer, from your perspective as a radiation oncologist, where do you see the intersection between radiation therapy and immunotherapy? Is there an intersection in this disease?
So it's a good question, Dr. Denlinger. I think that there appears to be some relationship between radiation and the immune system. In some diseases, it's a little bit more clear than in pancreatic cancer. But I think, we have good laboratory evidence that suggests that when you treat pancreatic tumor and certainly other kinds of cancers with radiation, something happens where that tumor then can wake up the immune system. However, I don't think we're ready yet to really treat patients in that way. I think what we need to do is to continue working to refine these treatments to get them to the point where they work not just in cancer cells in the laboratory, not just in mice, but in humans. And so there are potential strategies that are exciting, but they're not quite ready from a radiation standpoint. There are other things that I think are at least ready to be tested at this point. So we are very excited about immunotherapy as a new tool to treat cancer. I mean, you know, for decades and decades, we only had surgery, radiation, and chemotherapy. Now we really have a fourth tool, which is very exciting, but we're just not quite there yet with pancreatic cancer.
So we're starting to get some questions in from the audience. So I'm going to direct my first question to Dr. Jain. And this is a question about adjuvant therapy. So after surgery, when you're cancer-free, you may be prescribed additional therapy after surgery is over as a way to help prevent the cancer from recurring. But if you don't have visible cancer, if the cancer has been removed, how do we know that the chemotherapy is successful? How do we know whether the chemotherapy is doing its job?
Yeah, so that's a really good question. So as Sanjay was mentioning earlier, we are shifting towards patients getting chemotherapy before resection of their pancreatic tumor for a variety of reasons he mentioned. However, there are patients that get the tumor resected up front and then sit down with us in the office to discuss the role of extra chemotherapy on the back end. And the role of that chemotherapy is to kill what we consider micrometastatic disease. So I think, Crystal, your question was sort of alluding to that the patient felt that they didn't have any cancer in their body. And that is true in a sense that when we do our CAT scans or PET scans, you know, or blood work, we're not able to identify any residual disease. However, what we know is that over time, this disease can come back, and that could be a spot that pops up in the liver or lung. And what that means is that there was a microscopic cancer cell that had already escaped the tumor and spread. And we're trying to eradicate those cells with the adjuvant or post-operative chemotherapy. And now the data suggests that we should be using combinations of chemotherapy in that setting. So that's something your oncologist may recommend. And just to wrap up, that is based off of data from phase 3 randomized clinical trials where patients were randomized to get you know, chemo or no chemo or multiple chemos versus one chemo. And ultimately the data supported that chemotherapy does indeed improve survival. So that's why it's considered the standard of care.
So Dr. Dotan, when someone finishes their adjuvant chemotherapy, what happens then? Do you shake their hand and say you're done, or do you end up needing to follow them? What happens after we finish the active therapy?
So we tend to follow patients very, very closely. I mean, you know, a few years ago, we didn't really know what adjuvant therapy can give us. But now, as Dr. Jain said, we have large studies that are really supporting the use of multi-drug chemotherapy that can prolong life. But we still worry about patients. So we are following them very closely and see them every few months in clinic and do scans. And the idea is to really identify anything, if anything were to come back, find it early because we have things to do about it. That's the goal here. We don't want to wait until things progress too much and then we can't help. We want to find things before they explode and when we can actually do something about that. So that's why we just do a very, very close follow-up and make sure we monitor patients very carefully.
Crystal, can I add something real quick?
Yeah, absolutely.
You know, I always tell patients, and I think there's a bunch of people on Facebook now about this, like the weeds and seeds of pancreatic cancer, right? So I'm a big proponent of delivery of chemotherapy up front for the reason that these microscopic things that Dr. Jain was talking about, these little weeds and seeds everywhere, I can't remove, right? Surgery is not going to remove those. And chemo is a way to kill it. It's your weed be gone. It's your Roundup. It's your weed killer. And then eventually, once you get through that, and if there was stuff that's outside that we can kill, then I can come in there and pull the plant out of the ground. But it's just, again, it's just the idea that this disease is really beyond a single person. It's really the group. And with the team effort, we can really offer patients optimal care. So I think it's just important for patients to realize that, again, the delivery of therapy in the upfront setting is important just for that reason.
Yeah. So Dr. Asadorov, you straddle between the lab and the clinic. What are some of the challenges that you see in pancreatic cancer treatment, and how are you trying to translate that back into the lab? I'm going to ask that to you first, and then I'm going to ask Dr. Kuckerman to add in, how you're attacking some of those challenges that Igor is bringing back from the clinic, and tackling them in the lab as the PhD. So Dr. Asadorov, what are your thoughts being the translational person?
Well, thank you, Crystal. I just answered in text messages in Facebook some of the questions that were asked. And really, the problem with pancreatic cancer is that typically active approaches like immunotherapy, for instance, very amazing results in melanoma, lung cancer, renal, many cancers. The standard approaches don't work, like drug like Keytruda, for instance. We tried and there is zero effect. We're trying to understand why this is the case. One of the reasons is that the tumor microenvironment, this bridges over to Eti's specialty, is very immunosuppressive. When we calculate the number of cells that constitute the cellular mass of pancreas cancer, 50% of these cells are immature myeloid cells. The rest is 40% of fibroblasts, and only 5 to 10% are the actual cancer cells. So these very tricky cancer cells are masters of disguise, and they attract other cells to kind of bury themselves like in a needle in a stack of hay, in a haystack. So it's very difficult for chemotherapy and active immune cells to penetrate through this mess. So what we're trying to do is to disentangle this meshwork of inflammatory cells and fibroblastic cells. And so, as you know, there were a number of clinical trials that produced so far mixed results. There was an attempt to deregulate the stroma with hedgehog inhibitors by Genentech, and actually produced worse disease. There's an idea of dissolving the matrix with hyaluronidase, an enzyme that digests the collagenous stroma. Again, the results are not so far that encouraging. So we're trying to do smart things, like for instance, repel the myeloid cells not to come to pancreatic tumor bed. This is in collaboration with the University of Rochester, Darren Carpizzo. So we are conceptualizing clinical trial. Hopefully, if we secure funding, and we're actually writing grants on this. So that will be one approach. Another approach that will be launched in 2021 is to really normalize the stroma. Instead of destroying it, we will normalize it by very sort of accessible means. Like you take high-dose vitamin D IV, you take anti-malarial hydroxychloroquine, nothing to do with Trump, and losartan, which deregulates TGF-beta. So when we give it to the patients during the window of time when they finish their radiation and chemotherapy, and before they go to surgery, the idea is to really suppress this activated stroma and make these cancer cells to suffer, not to survive the onslaught of chemotherapy and radiation. So when Sanjay goes to the OR and takes these tumors out, we would really like to see not to see any more cancer cells left behind. So that's the idea.
Yeah. And Dr. Kuckerman, how do you, as the PhD of the group here, attack these questions? You come to our tumor board, you listen to us talk, and then you go back to your lab. What challenges do you see coming from that perspective of being the basic scientist here?
Thank you for the question. So Dr. Asadorov actually gave a great introduction to what we do in the lab. We actually work together with Dr. Reddy, and we get samples from surgery, fresh samples served to isolate cells live, and then we can reconstitute all of this environment where the cells live inside the patients, as opposed to culturing them on petri dishes, which are very stressful for the cells and nothing like inside the pancreas. And so by doing that, we can let the cells do what they do best, which is derive all of these scaffolds and all of these entanglements that Dr. Asestarov was talking about. And we can then really study the cells in their own natural environment and start to really understand what is that causes them to behave so immunosuppressively and so trying to refract the immune system and trying to protect the cancer. And why is it the physics of it is not diffusive and we cannot get the drugs in, and all of that biophysics aspects of it together with the biochemistry. So using these models, we can come up with new targets and new means to actually normalize it back to disentanglement, so the good cells can come back in and kill the bad ones. And so those types of things, with the wonderful team that we have behind the scenes, we work all the time with the cells that we harvest from surgery. And at the end of the day, I have interest in going to your tumor boards, because that way I better understand what problems and what are the gaps that you guys have, so we can then open these new projects that we work with this mimicry that we have in the little, the little tumors in the lab, so we can actually try to test that and bring it back to you with those results and think together.
And that's what ultimately determines the next wave of clinical trials, which is, the way that we bring the cancer frontier forward. So, we know that clinical trials are certainly really important in driving the science forward, and that's especially true in pancreatic cancer. So, Dr. Dotan, what are the criteria that you should be considering to determine if someone is eligible for a clinical trial? And do clinical trials of patients with pancreatic cancer only include patients who have localized disease? Does it include patients whose disease has spread outside of the liver? Where do you see clinical trials playing a role in the treatment of pancreatic cancer?
Thank you. That's a great question. I think we are really lucky in this field that we have studies across all levels of disease. I mean, we have studies that are very early on when the disease is still localized and patients are getting treated before surgery. We have studies such as the one that Dr. Asestarov discussed that looks at something to give right before surgery. We have studies focused just on radiation therapy that are looking at part of the treatment that we give before surgery. And then if patients unfortunately progress and have metastatic disease, we have studies looking at every level of the disease. And in terms of eligibility, most of the studies really require patients to be very fit and very healthy. And the reason is we are trying experimental treatments. And some of these treatments, we don't know 100% how they're going to affect the patient. So we really need the patient that go on these trials to be healthy and fit. But as I said earlier, one of my areas of interest is looking at older patients that may not be that fit and may not be able to go on clinical trials that require you to be very robust. And for that, we actually have a study looking at vulnerable patients. So we have a national study that is focused on this patient population that's more vulnerable, that maybe in the community, doctors would be scared to give them chemotherapy. And we're trying to refine how chemotherapy will be given to this patient population. So I'm really proud to say that when we're thinking about clinical trials in pancreatic cancer, we think about all stages of this disease, all types of patients, and really trying to move the field forward, not just for those patients who can really get everything that they can and are very fit, but also for the ones that may need more support and more help. And I'm proud to say that at Fox Chase, we are thinking about that whole spectrum in terms of the clinical trial program.
Yeah. So Dr. Dotan, you have actually spearheaded some of these efforts with national studies. She's the national PI of a very large study looking at vulnerable pancreatic cancer patients in older adults. And so that's a very exciting effort. So Dr. Reddy, you also look at fitness when you're thinking about surgical options for your patients. And there are a number of different surgeries that we can offer our patients. There's the Whipple procedure, there are distal pancreatectomies, total pancreatectomies. So what are the different types of surgeries that you potentially may offer a patient? What kinds of things do you take out during that surgery? And how do you decide who gets to go to surgery or not?
So, the idea of fitness is probably one of the most important things. And, if a patient's healthy, age is a number, right? And age should not preclude you from undergoing an operation alone, but it's the comorbidities that may be associated with it that could. The type of operation offered really depends on the location of where the tumors are. And this is the tough part about pancreatic cancer. You think about pancreatic cancer, the first word that comes to your mind is a Whipple, but not all pancreatic surgery is a Whipple. A Whipple is when you have to remove the head or the neck of the pancreas for the uncinate process to the right of the gland, to the right. Then you have the neck, then you have the body, then you have the tail. And every part of that pancreatic resection is essentially a different operation. The real tough part about the operation in these surgeries is that you're dealing with a pretty small tumor in general, but you're dealing with a very fibrous, and this is kind of to Dr. Cooperman's area, a very fibrous tumor that is just kind of encased in this like thick rind of tissue. And while the tumors are small, the stuff outside can be large. And where it becomes particularly challenging is when the blood vessels are involved, right? So when you have a tumor that's either away from a blood vessel or abutting a blood vessel or then wrapped around a blood vessel, it's really a different beast. And the treatments of chemo and radiation oftentimes help us turn this into this to make it resectable. So again, patient selection is very important here. And, the type of operation that ends up being offered is really depending on where the tumors are located in the pancreatic gland. So every operation is not a Whipple. There are other types of pancreatectomies. The Whipple is probably the most complex and advanced of the operations offered, but the other ones are not easy either. And again, it really is just relies on the fact of where these tumors are in relation to the blood vessels.
So that's great. It sounds like there's certainly a lot of things to consider from a surgical perspective. And Dr. Meyer, from a radiation perspective, does location of tumor, does the fitness of the patient play in a role? Tell me a little bit about how you think about radiation technologies and techniques and how you determine what new versus older techniques you're considering for your patients with pancreas cancer who need radiation therapy.
So we really have to think about things in terms of size, in terms of location, in terms of what is going to make Dr. Reddy's life easier, or situations where we know, as great a surgeon as he is, he will not be able to take this tumor out surgically because of exactly where it is, frequently because of blood vessels that the tumor is involving. And so that all together with the patient and the patient's fitness and the patient's age and tolerance and all that sort of stuff will help us to figure out which of these treatments is best for the patient. Am I trying to do as much as I can to replicate what could be done in the operating room by an experienced surgeon, or am I confident this patient's going to get surgery and trying to augment that or make that easier? It's a big decision point for me. The other thing that I want to mention briefly is that there is another technique that we are investigating in our department that is actually brand new, really not being utilized anywhere else in the Western world, which is a treatment of a tiny bit of radiation that activates a particular food additive, actually, that people take and allows us to treat these tumors that people can have, and it could be over a variety of different sites, and treat them in an entirely new way, where that additive gets concentrated in tumors. We activate it with a tiny bit of radiation, and patients can hopefully have a response. This is a brand new treatment, so this is a phase 1 study. It really is experimental, but we're optimistic that it will work and it will be done safely for patients. So, we're always trying to push the envelope, trying to find new ways of helping patients who are struggling and combating pancreatic cancer.
So we're getting close to the end of our time, but I do have one last question that I think is important. And I'm going to give this to Dr. Dotan, actually. So different centers really offer different things. Dr. Meyer just talked about a study with a technology that we only have here. So if different centers are offering different options for treatment, how do I know which is right and where I should go? And is there one that's best?
That's a really good question, but I would say difficult to answer in one sentence. I do think that this is a disease where you have to feel very, very comfortable with the team that's treating you. I think it's important to be in a center that offers you a multidisciplinary approach, that you really get to interact with the surgeon, with the medical oncologist, with the radiation oncologist, and you are sure that they're all looking at your case with their pair of goggles, right? They're like really thinking about what your treatment requires. So that would be the one thing I would recommend for patients to think about when they're selecting their treatment team. I do think there are differences between centers, and the only way to really assess those is if you're not sure, go for a second opinion. There are, a lot of we're lucky in our area, a lot of options for that, and there are a lot of good centers around. And I think when you do go for a second opinion, make sure you see the right people and make sure that if you do need this multidisciplinary approach, you get that evaluation through every single member of the team.
Yeah. So that is our time for the evening. I really appreciate to all the patients and caregivers and family members and survivors and advocates. I appreciate you spending your time with us this evening. I'd like to again thank our exhibitors and our advocacy groups for your support and participation. I want to thank our faculty members for joining us this evening. I'd like to thank the patients and survivors and family members for sending in messages and pictures for our wonderful slideshow today. And our next event for Fox Chase is actually going to be the Tree of Life celebration, which is scheduled for Wednesday, December 9th. And this is one of my favorite traditions as a Fox Chase physician. And it is going to be held virtually this year. So please check our Facebook page and our website for information about the Tree of Life celebration. It's certainly a wonderful celebration of our family members, friends, and our loved ones who are living, surviving, and have passed from cancer. I want to wish everybody a very happy and healthy holiday season. We are excited to have been able to do this virtually, and we hope in the future we'll be able to gather together again soon. Good night to everybody, and take care.